Good afternoon. My name is Chelsea from Mission. I would like to thank Dr. Vora and Dr. Taghva for doing this webinar with us today. And thank you all for joining us for this webinar. Without any further wait, we're going to have Dr. Vora start. Thank you.
Thanks, Chelsea. Thanks to all of you that tuned in today on this Saturday afternoon to listen to Dr. Taghva and I speak a little bit about essential tremor and deep brain stimulation surgery for essential tremor. Before we get started, I just wanted to introduce myself to those that are unfamiliar with me. I'm a local product out of here from Orange County. I did my undergraduate training in neuroscience at UCLA. Stuck around Southern California for my medical school training, and then went over to Phoenix, where I did my residency in neurology over at the Barrow Neurological Institute. Over there, I was exposed to this innovative therapy called deep brain stimulation surgery that really intrigued me when I first saw how effective it was, not only for treatment of Parkinson's disease, dystonia, but also for essential tremor. So much so that I decided to stick around for another 2-year fellowship in the 120-degree summers out there to learn more about it. And I'm excited today to talk to you about deep brain stimulation surgery and how it can be applied for the treatment for essential tremor, which is one of the most common neurological disorders that we see in the clinic. And so both Dr. Taghva and I will hopefully get a chance to answer any questions that you may have about the therapy as we talk further about it today. So without any further delay, I'll go ahead and get started and segue into our talk about essential tremor today. So what is essential tremor? Basically, essential tremor or tremor in general is any rhythmic oscillation of the body, of any body part. Most commonly, we see it in the hands, arms. The essential tremor basically is describing an action tremor or tremor that occurs when that particular limb or body part is in motion, action. So typically when the hands are outstretched or when there's engaged in a certain task like using utensils, carrying a cup, writing, so on and so forth. It is thought that essential tremor is due to a dysfunction of the circuitry involving the cerebellum or the back part of the brain that's involved in coordination. And then that's projection of that part of the brain to the deeper structures of the brain called the thalamus, as well as the surface of the brain or the cortical projections from there. And as I mentioned, essential tremor is one of the most common movement disorders, if not the most common movement disorder that we see in the clinic as a neurologist. It's very common, as I mentioned, about 10 times more frequent than Parkinson's disease. So there's estimated to be about 1 million or 2 million patients with Parkinson's disease in the United States, and there's about 10 times more patients that are affected by essential tremor. Before, we used to call it benign essential tremor. We got rid of the benign part in the name, in the nomenclature, because it is kind of a slowly progressive disorder, and the tremor can be disabling and limiting for a lot of patients, where it can get in the way of what they want to do, their quality of life. So really, we don't use the term benign essential tremor anymore. We just call it essential tremor. There is about a strong, potential genetic component to essential tremor, and we do see that most patients, about 50% of patients with essential tremor, oftentimes they'll have a first-degree family member that also had essential tremor. Although some of the genetic loci, the genes that are possibly causing essential tremor, those have been tough to elucidate. And the worldwide prevalence of essential tremor is estimated to be about 1%, although I think that's a pretty conservative estimate, probably a little bit higher than that. And so as I mentioned, essential tremor is mostly characterized by an action tremor, or tremor that occurs when that particular body part is in either held against gravity, as in what we call postural tremor, or when it's in motion, engaged in a task, voluntary movement and what we call kinetic tremor. And this is oftentimes what we see when there's tremor that occurs with the hands when engaged in using utensils, such as when feeding, eating, carrying a cup, when drinking, writing, and sometimes even the voice box, the vocal cords can become tremulous and cause a vocal tremor with essential tremor. Sometimes there can also be involvement of the head and neck, which results in a little bit of a head tremor. And sometimes patients with essential tremor can have a little bit of head shaking side to side or up and down as if they're saying no or yes as well. And so here are some videos of what we commonly see with essential tremor. This is the characteristic tremor that we see with writing with essential tremor. And as you can see there, the handwriting is difficult to read, it's a bit tremulous. And here we see the action tremor of essential tremor. And oftentimes patients will use the contralateral limb there to stabilize and help bring the cup up to the mouth without spilling. And here, another example of essential tremor. And if you listen closely, you can hear a little bit of the vocal tremor quality to the voice as well.
I am left-handed, so my left hand is more dramatic than my right. There's a little tremor on the right, but it's very dramatic.
And she was also describing that there can be a little bit of asymmetry with the essential tremor. It generally involves both sides, but in her case, she was saying that the dominant side, her left hand, was a little bit worse than the right side, which we commonly see with essential tremor. There may be a little bit of asymmetry between the two hands. So once again, we got rid of the term benign essential tremor because we do know that the tremor can progress over time and it can cause some functional impairment, it can affect patients' quality of life, it can affect hobbies, job-related duties, and so that's why we don't necessarily call it a benign tremor anymore. We do know that it's very, very common. The prevalence of it increases with age, so it's estimated that about 5% of patients after age 60 or so can potentially be affected by essential tremor. As I mentioned before, that there can be a strong familial component to it with first degree relatives that are often affected in patients that have essential tremor. And then there is sometimes this responsiveness to alcohol that we see with essential tremor, although not in everybody, and it's not for obvious reasons the preferred treatment for essential tremor. But some patients do note that when they do have a glass of wine or an alcoholic beverage, that the tremor dampens, has a little bit of a calming effect on their tremor, so makes their tremor a little bit less prominent. And then once again, this is just a slide depicting the various parts of the body that can be affected by essential tremor. Most commonly the hands over here with handwriting. Less commonly, the legs can be affected, but they can be affected and have a little tremor in them. And then, as I mentioned before, there can be a head tremor as well. Now, over the course of time, even though we've known about essential tremor for a very long time, there haven't been very many breakthroughs in terms of medication treatment for essential tremor, unfortunately. We do have some tried and true medications. The most commonly used medications are beta blockers, such as propranolol and primidone, which is the medication that we borrow from the seizure class of medications and would be used for tremor suppressive purposes and not necessarily for seizure purposes. But those are the two most common medications. And generally, these medications can be effective for many patients. In about 50 to 60% of patients, they can have tremor mitigation with these medications. But there can be progression of the tremor and the underlying disease over time. And so some of these medications, unfortunately, they may lose a little bit of efficacy over time. And sometimes there are patients with essential tremor that don't respond as adequately as we would like to the medication. Then there are the second and third line medications, and some of these medications are anti-anxiety type medications like the benzodiazepine class of medications with Xanax, Klonopin. Generally, these aren't good medications to use on a long-term chronic basis because they can be habit forming. They lose efficacy over time because of tolerance to the medications. And then there's some other medications that we also use, such as gabapentin, topiramate. These are more third-line medications with variable efficacy, but they can have some effect for some patients. And so once again, it is estimated that about less than 60% of patients with essential tremor are helped overall by these medications. So there is, limitations to what we can do in terms of medication therapy with controlling essential tremor. There's some non-pharmacological strategies that we use as well, such as biomechanical loading, which just basically describes putting external weights or pressure loading on the affected limb to try to help dampen the tremor. And then there's other adaptive equipment that patients will use as well, such as weighted utensils or a heavier pen. Those things can sometimes help with mitigating the tremor as well. And then, of course, the surgical or ablative procedural type of treatments for essential tremor, which are very effective. And so some of those we'll touch upon today. And then, of course, Dr. Taghva will talk a little bit more about deep brain stimulation surgery for essential tremor as well. So some of the ablative options that we have for essential tremor treatment include high frequency focused ultrasound and then gamma knife radiation. So basically, these techniques are delivering certain wavelength, or in the case of gamma knife radiation or high frequency ultrasound, to a certain spot in the brain that we know is implicated in tremor generation. And basically what we're doing here is trying to burn a little hole in those areas. Now, these are effective treatments for a subset of patients with essential tremor, but there are some limitations to these therapies. Generally speaking, these therapies can only be used for one side of the brain, meaning they can only be used to control one side of the body, the tremor one side of the body. They also are pretty much one and done techniques, meaning that there really can't be any adjustment done to them once the whole hole has been burned in the brain where we're trying to create that lesion. So it's not necessarily something that we can adjust once it's done. And potentially there can be side effects with these types of techniques where it can result in numbness or trouble with balance or trouble with speech. And so unfortunately, because it can't be adjusted, we can't really go back and try to account for those side effects if there are any with these types of techniques. Now, deep brain stimulation surgery is a little bit different in the sense that we can create mimic the burning of the hole essentially in that area of the brain that is involved in implicated in tremor generation, but we can do so without necessarily creating a permanent hole there. What we're doing is using electrical stimulation to create an electrical field and influence the circuitry in that brain, and thereby creating a more homeostatic firing pattern in that brain and mitigating tremor in that manner. The good thing about deep brain stimulation surgery is that we can adjust the therapy so we can change the amount of stimulation given into that area, and that way we can help shape the electrical field and we can avoid side effects potentially in doing so. We can adjust the therapy if there is side effects. We can always turn off therapy as well, so it's reversible in that sense. And it is a very effective tool in terms of mitigating tremor, especially with those patients with essential tremor where it is impacting their quality of life, their hobbies, their daily activities. So it is something that both Dr. Taghva and I are very passionate about, because we've seen how impactful it can be for patients afflicted with essential tremor. Now, it's also important to realize that there are other things that can cause tremor as well. Namely, there are a lot of medications that can produce tremor. So what we commonly see in the clinic is a lot of the heart medications, antiarrhythmic medications can produce tremor. Certain mood medications can also have create a little drug-induced tremor as well. Some of the medications that are used for treatment of asthma, COPD, can exacerbate tremor, and then the list goes on and on. So it's important to get checked and make sure that there isn't anything else that would be potentially exacerbating anyone's individual tremor as well. And that's what this slide is highlighting. It's also important to get checked out because there's other things that can cause, tremor as well. Although essential tremor is the most common form of tremor, there certainly are other diseases that we see in the field of neurology that can produce tremor and sometimes can mimic or have a similar appearance to essential tremor. Parkinson's disease, for example, multiple sclerosis, Wilson's disease, dystonia can also produce a tremor. So there are other etiologies for tremor, other causes for tremor, and it's always important to get a thorough history and examination to make sure that the tremor that any one individual has is accurately diagnosed as essential tremor in order to help dictate the most appropriate treatment for that type of tremor. And this slide is just highlighting some of the things that we do in the office. Commonly when evaluating tremor, I'll have folks produce a handwriting sample and do some of these spirals and things of that nature to help distinguish between various tremor types. And this is just highlighting some of the changes that we see with doing these certain little tasks in the office with various disease states that can produce tremor. So in Parkinson's disease, we typically see what we call this more cramped and micrographia type of spiral where it's a little bit more tight and a little bit shaky. Whereas in essential tremor, we see this pattern over here onto the right more commonly. And then once again, this is just highlighting some of the different characteristics between Parkinson's tremor and essential tremor. The main differences here are that Parkinson's tremor, the Parkinsonian type of tremor, is generally presents more asymmetrical. So generally there's one limb that's affected first and more prominently first, whereas essential tremor tends to be more symmetric, tends to affect both sides of the body, although there can be a little bit of asymmetry. And then the main difference also is that the Parkinson's tremor is more predominantly a resting type tremor, meaning that when the hand is idle or the limb is idle, that's when the tremor is more prominent. Whereas with essential tremor, it's more of that action tremor that we saw in the videos before when the hands are engaged in activity as opposed to being at rest. And then certainly the response to medication is different as well, whereas essential tremor can respond to more of the conventional medications that we talked about, the propranolol, primidone, whereas Parkinsonian tremor would respond to medications typically for Parkinson's disease. Now there can be considerable overlap, and sometimes it's tough to distinguish just on the basis of clinical features alone in the examination as to whether a tremor is more Parkinson's disease or more essential tremor. Not everything follows the textbook, and so in those cases there is a special scan that can be done called a DAT scan, and that can help distinguish between Parkinson's disease and essential tremor. And so this is just a little graphical depiction of where patients typically present on the spectrum with regard to essential tremor. So oftentimes their patients will have a little bit of tremor, but perhaps they're not bothered by it. In those cases, we don't necessarily have to treat the tremor, particularly if it's not impacting any activities, hobbies, or quality of life. Oftentimes, by the time patients present to me, they're kind of at that cusp where it's starting to get a little bit more bothersome. It's maybe progressed a little bit, and their tremor has, and so they're considering medication options. In which case, we would entertain trying one of those medications that we had discussed earlier. And then there can be, as I mentioned, progression of tremor over time, and so that's when we start to entertain more of the more advanced therapeutic options, such as deep brain stimulation surgery for controlling the tremor, particularly when the medications prove to be suboptimal in terms of controlling the tremor, or if medications were once effective but are now declining in efficacy because of tolerance or because of progression of the tremor. And that's when we start to look more towards deep brain stimulation surgery as an effective tool for mitigating tremor. And as I mentioned, and as Dr. Taghva will talk more about, deep brain stimulation is a very effective tool for tremor reduction. The data, the literature states that in about 80% of reduction in tremor can be achieved by DBS. And in reality, we even see sometimes there's cases where there's greater than 80% tremor reduction, and we'll show some videos that highlight that. The other good thing about deep brain stimulation surgery is that the response is very durable. So whereas the medications potentially decline in efficacy over time due to disease progression and due to tolerance to the medication, deep brain stimulation surgery, according to the data that we have right now, and that's continuing to come out, tends to be a very durable therapy. And we have literature that shows that it can be effective for 10+ years with very good suppression of tremor. So it is a very useful therapy, and it's very good therapy. And I think it's probably better if I show you the videos here to kind of illustrate that point. So once again, going back to our patient examples here in the past, this is the handwriting of essential tremor again. And we saw the difficulty raising the cup because of the tremor.
To both hands, my throat, and my
And
feet.
similarly,
The cup I drink out of all day long.
the shaking there.
I can steady it with two hands, but not with one. I am left-handed, so my left hand is more dramatic than my right. There's a little tremor on the right, but it's very dramatic.
And all of these patients had deep brain stimulator surgery done, and now we'll see the effect of the stimulator when it's turned on. And so you can see there that the handwriting is much more steadier, much more legible with the deep brain stimulator turned on, and then back to the comparison off when the stimulator's turned off. And there's the shaking with the stimulator off. He turns on the stimulator there with a flip of the button there on the phone, and much steadier.
Okay. So it's turned back on now. See how easy that was. Just get this dramatic change. You can actually pick it up with one hand and not impale myself with a straw. Still shakes a little bit, but nothing compared to what it was. Coffee cup. Up to the mouth, back down.
And so you could see there some good examples of how effective DBS surgery for essential tremor can be. And certainly all those patients were very pleased with the results. The last patient did still have a little bit of tremor, but as you can see from a functional standpoint, very good results, being able to carry the cup without shaking, bringing it to the mouth without spilling. And here's a patient of both Dr. Taghva's and mine that we recently did deep brain stimulation surgery for essential tremor within the past 6 months or so. Here's an example of what his tremor is like when the deep brain stimulator surgery is off. And as you can see there, that there's what we would call a moderate amplitude tremor there. with action when trying to reach a target. You can see that the tremor is more amplified there when trying to get to my finger there or trying to touch the nose. And then this is when the deep brain stimulator surgery, the deep brain stimulator is turned back on. You can see there that both hands are much more steadier in achieving, in reaching the target, as well as just with posture and with holding the cup there. And one of the great things I think about our patient is that you don't see it in the video here, but his wife is sitting in the room there with us, and she had, mentioned that not only were they very pleased in that he was able to, hold a cup, hold utensils, things of that nature, but she had noticed benefits in her quality of life as well, because they had, said that before, even without realizing it, they had, previously been avoiding going to social gatherings, restaurants, things of that nature because of the patient's essential tremor and his avoidance of wanting to be shaking in public settings. And so after the stimulator surgery with the good results there, they were able to get back to more of a sense of normalcy with regards to their social life and improvement of not only the quality of life of the patients, but also of family members, caregivers, and so that's always a good thing as well. So the benefits of the DBS for essential tremor can be seen, not only with patients but also with those that are also affected by those quality of life restrictions. And next, I'll hand over the presentation to Dr. Taghva to talk a little bit more about the surgical aspects of deep brain stimulation surgery and DBS itself.
All right. Okay. Thanks again, everyone, for making time on a Saturday to hear us talk about essential tremor and deep brain stimulation. That was a great introduction by Dr. Vora about some of the characteristics of essential tremor. One of the things that, in my mind, has really been a distinguishing feature of our program at Mission Hospital has been having a dedicated movement disorder neurologist like Dr. Vora, because as he mentioned in his talk, there is a lot of interplay and ways to make the diagnosis between essential tremor and some of the other causes of tremor, including Parkinson's disease. And it's really important to be evaluated by a specialist in order to get that diagnosis right. And so, that's been a great addition to our program. Some of those distinguishing features kind of made me think about some of my own interactions with patients. And one of the things we always ask patients in distinguishing essential tremor is does your tremor respond to alcohol? And so I remember one patient, I said to them, an essential tremor patient, I said, well, does your tremor respond to drinking alcohol? And they said, well, I don't drink. And then I said, well, why do you ask? I said, well, typically essential tremor versus Parkinson's disease, essential tremor will respond to alcohol. And so they asked me, well, oh, should I start drinking? And so just to be clear, we're not advocating the use of alcohol for management of this disorder, but it is a distinguishing feature of it. Let me advance our slide here. So this is a little bit about me. So I'm originally from Las Vegas, Nevada. I've been here in California probably for the last, I would say 15, 16 years. I've been in practice at Mission Hospital for the last 8 years. Prior to that, I did my degree in biochemistry at USC, and then did my medical degree at Johns Hopkins, and then came back to USC to complete residency. I did my fellowship in neuromodulation, so specifically spent a year doing only DBS and other forms of neuromodulation, one being spinal cord stimulation. and I did that at The Ohio State University, and have went to Mission after that and have been here since. Deep brain stimulation has actually been around a long time. Um, Really, the initial forms of DBS were around in the 50s and 60s, and the first prototypes were in the 70s and 80s, and the product became much more widely used in the 90s and early 2000s. Now, what has been really exciting about the last 5 years in deep brain stimulation is that we've really hit a new innovation cycle. The main distinguishing feature of that is now we are able to implant directionally stimulating DBS leads. What makes that really exciting is that typically with deep brain stimulation, part of the key to having a good outcome is stimulating parts of the brain that will give you improvement in the tremor, but trying to avoid stimulation of the surrounding areas of the brain. And what directional deep brain stimulation allows us to do is really fine tune and be very precise about where we're delivering electrical stimulation to the brain. As far as DBS and movement disorders, so when I say movement disorders, the two main disease states that we use DBS as a therapy are Parkinson's disease and essential tremor. We also use it in some cases for dystonia, some cases for epilepsy, and we were actually the first program in Orange County to implant a DBS for epilepsy. But what DBS does for movement disorders is it stabilizes the circuits of the brain which cause tremor. And the way I sort of think about it is like a pacemaker for the brain. So if you had, for instance, an irregular heart rhythm, and we implant a pacemaker to regulate that rhythm, DBS is doing very much the same thing in the brain. Now, what distinguishes DBS from some of the older procedures, such as lesioning procedures or things like focused ultrasound, is that the stimulation can be changed, it can be adjusted, it's entirely reversible. Those distinguishing features really make it valuable. The other distinguishing feature of it at this time is versus lesioning procedures that are available, such as ultrasound, we can actually treat both sides of the body. So typically for patients with essential tremor, unless they have just one side that the tremor bothers them, we will often place electrodes on both sides of the brain in order to control the tremor on both sides of the body. In addition, it tends to be very important to place electrodes on both sides of the brain in order to treat some of the things like head tremor or vocal tremor. And again, the way DBS works is the stimulator sends electrical pulses, much like a pacemaker, to the lead, and the lead basically delivers a stimulation to a targeted area of the brain. And again, with directional stimulation technology, we're now able to really fine tune on a millimeter basis where the electrical energy is being delivered. The DBS procedure typically is done in two parts. So the first part involves imaging and planning, and typically after I see a patient in the office and in conjunction with Dr. Vora's recommendation, we'll move forward with planning the surgery. And typically what's involved in that is getting a very high resolution MRI. And what that helps us do is target to sub-millimeter accuracy using a patient's own anatomy, where we are able to target the areas in the brain where we want to deliver stimulation. The stage 1 procedure is where we actually implant the lead. That procedure typically takes about half a day if we were doing both sides of the brain. So most patients show up, we start surgery around 7:30, 8 a.m., usually done somewhere between 10:30, 11 a.m. And after this procedure, patients typically stay 1 day in the hospital. During this procedure, we are able to test and make sure that the device is accurately treating the tremor and making sure that we have no side effects from the stimulation. And once that's done, we are able to, we stop the procedure and take the patient to the recovery area. The stage 2 procedure is done on an outpatient basis, and basically this part is done under general anesthesia. And what we do at this time is we basically just connect the electrode that was implanted in the brain to a battery. The battery is most often placed just below the clavicle, kind of similar to an area where pacemaker would go. More often than not, now with some of the new battery technology, we are implanting one battery, even if we're putting electrodes in on both sides of the brain. So one battery can run both electrodes. And after implant, we start programming typically anywhere from 3 to 5 weeks after the stage 1 procedure. The reason we wait is most patients get an initial effect with reduction of their tremor just from placement of the leads. And that effect lasts anywhere from 1 to 2 weeks. Once a patient has the electrodes placed, even with the electrodes off, they do have some reduction of tremor. The tremor slowly comes back after a couple weeks, and at that point, we turn on the device and we find the optimal program. And this is done in Dr. Vora's office. And typically, optimizing the device will take a few visits, but patients get some relief of their tremor right away. As far as what makes patients a good DBS candidate, as typically what we see most patients have who go forward with DBS are tremors that really interrupt their quality of life. So Dr. Vora showed some videos with patients unable to write, unable to feed themselves, unable to drink out of a cup. Those are all the things that sort of lead patients to DBS. And as he said before, medication options are very limited with essential tremor, and typically, somewhere around 60% of patients get some relief with medications. Now, other things that we look for are typically patients with severe cognitive impairments are not candidates for DBS. And typically we ask that patients be medically stable and off things like blood thinners for surgery, et cetera. With DBS placement, electrical stimulation, there are certain side effects that can happen with stimulation. And that's why I believe it's so important to now have the option of using directional stimulation leads. Now, the common side effects that people feel with stimulation, especially during the initial mapping, are things like muscle contraction, paresthesia, which is just a tingling sensation. Sometimes people get some slurred speech or impaired balance. Now, what I always tell patients is it's normal to have these effects during the initial programming. And actually it helps us really with the fine tuning of the device, because what we're able to do then is know physiologically exactly where we need to stimulate while avoiding these areas. But these stimulation side effects are easily controlled. Whereas some side effects with the lesioning procedures, and when I say lesioning procedures, I mean some of the old style procedures and some of the new ones, such as focused ultrasound. If you have side effects, we can't reverse them. And so that's really a big distinguishing feature of DBS, is that all of these stimulation related side effects are reversible. And again, having a directional lead, meaning a lead that can stimulate in certain directions, whether it's forward, backwards, left, right, really allows us to optimize how much symptom control we get while limiting the side effects. Here's a video showing how this works. All right. And one thing that has really been a big advancement in this directional stimulation is that one company, Abbott, does have FDA-approved bilateral DBS indication for essential tremor. We touched on it earlier, but as far as lesioning procedures, focused ultrasound, and other DBS manufacturers, they're only FDA approved for doing one side of the body, where here now we're able to do both sides of the body, control the tremor on both sides, and that really has been a game changer for us in our practice. You can see here the data really speaks for itself. Most patients with essential tremor get 80 to 90% tremor reduction with DBS therapy, and the vast majority of patients benefit from DBS placement. This new directional therapy, it has been preferred in patients where they had a prior DBS system that was not directional. We've changed it over to a directional system. And what I would say about DBS, and it's very unique in my practice, is it's really what I would call one of the most underutilized therapies. I generally see that a lot of patients are anxious about surgery before going forward, but once they have it, essentially every patient says to me, well, I wish I had done this sooner. It really changed my life for the better. And as we showed in the videos, really one of the most important things outside of the data is the improvements in quality of life. And it's hard to put a number on that. So when I tell patients, well, your tremor may get 80 to 90% better, while that's helpful for people to sort of frame whether or not they want to go forward with DBS, what really makes this a valuable therapy is that patients' quality of life improves dramatically. And this can have all sorts of auxiliary benefits, including you're going out and socializing more. A lot of patients I have are afraid to socialize or be seen in public because their tremor embarrasses them. They're afraid to go out to a restaurant. Hopefully in the post-COVID world, we can go back to restaurants again, but you can see how being able to now go out in public, being able to socialize with friends, being able to eat in a restaurant really improves quality of life beyond what the numbers show. Finally, this is something that most insurers, including Medicare, really all basically pay for. And the reason is they understand that this is a transformative therapy. The data is very good. The patient's quality of life is improved. So the cost with insurance is really a non-issue for this therapy. I've not seen any problems getting this approved through insurance. And kind of highlighting, I said about these are the quality of life is sort of the intangible thing here with DBS. This is a snippet from an article that was in our Health Matters magazine of a patient of mine, Mr. Broadleaf, who basically was essentially paralyzed by his tremor. He had zero quality of life, and he had been bounced back and forth. They had moved around the country, seen different neurologists, and unfortunately, no one had really introduced him to DBS. So luckily, he found us. We placed the electrodes, and he was 78 at the time when we placed the electrodes, and really transformative. I mean, here in this article, he said he had 95% less tremor, and some of the things that I didn't fully appreciate till I had met Mr. Broadleaf was really the emotional impact that some of these diseases like essential tremor have, not only on the patient but the family around them. And with Mr. Broadleaf, his son used to come to all the appointments, and I can tell you that after surgery, the patient was happy, but I can tell you the son was, he just said, look, I haven't seen my dad this happy in the last 10 years. And his life really was changed for the better by this therapy. So I encourage you, if you haven't read this article already, to find it, and if not, we can send you an electronic copy of it. So that ends my presentation. We have some time for question and answers. If you can type in questions and we can answer it. If any of you are having trouble doing that, we'll try to figure out a way to get your questions answered. But with that, if there's any questions, we can start taking them now.